Okay.
We are live, sir.
Go ahead. Yes.
Good evening, guys, and welcome back to the arthroscopy study group meetings. And it's a great pleasure that we invite all the eminent speakers, Nilesh Kamath, Vivek Pandey, Dr. Daftari, Dr. Karthik Selvaraj, and other panelists and moderators and the speakers for this wonderful meeting on bone loss assessment in glenohumeral instability. Without wasting much time, I would like to invite Dr. Nilesh Kamath to present his talk on bone loss assessment for glenoid. Welcome, Nilesh, and over to you.
Thank you, sir. So, in the meanwhile, as I set up my screen, let me thank Roshan and his team for the invitation. As usual, this has been a forum which is very interactive, and we, like last lockdown, we got to learn lots from this forum, and hopefully we continue the same during this lockdown as well. So my topic for today is how to quantify glenoid bone loss in cases of instability. And it's quite a relevant topic because shoulder instability is one of the most common clinical presentations in our outpatient practice. Okay. Yeah, okay. So we know that arthroscopic Bankart repair is more or less considered as a standard of care in cases of recurrent anterior instability. However, if you look at long-term results, and these results are in the best of hands, there is a failure rate of around 10 to 15%. And if you were to think about any failure, you need to find out the cause of the failure. So you're pondering whether was it the right procedure or was it the correct indication for the correct patient. So in that sense, this landmark paper by Stephen Burkhardt and Joe DeBeer was a real eye-opener, where they saw that when they revised or when they checked 194 cases in a retrospective study, they found that the failure rate was significantly higher, up to 67%, when there was a significant bone loss. And this percentage went up to 89% in contact athletes, which is completely unacceptable. And that is where they defined the concept of significant bone loss, which was either on the glenoid side or on the humeral side. On the glenoid side, a normal pear-shaped glenoid becomes an inverted pear shape because of anterior-inferior bone loss. And on the humeral side, in a position of athletic function, that is 90-degree abduction and external rotation, the Hill-Sachs defect starts engaging. I wouldn't be touching anything on the Hill-Sachs because I wouldn't want to encroach onto someone else's topic. So I'll stick my talk only to assessment of glenoid bone loss. What happens here? The problem is that whenever there's a glenoid bone loss, there is less shear resistance. So the lesser becomes the safe arc. As a result, in a position of athletic function, it tends to dislocate. If you look at this bone loss, it's not a single pattern. In an acute scenario, it could literally be an acute fracture, which still quantifies as a traumatic bone loss. It could be partial attrition, where Sugaya has shown that if you try to incorporate this fragment, it might still unite to the native glenoid and may prevent further instability, or it may be complete attrition. So identification of the pattern of bone loss is also extremely important. But the holy grail, which is yet to be found, is how much is too much. So stalwarts like E.G. Itoy had come up with this concept that although the initial ballpark figure was 25%, which was in DeBeer's and Burkhardt's paper, they spoke about a critical bone loss of 21% in an oblique fashion along the anterior-inferior part. This was further revised by Yamamoto to bring it down to 19% in 2010. As late as 2015, we had John Tokish and his team define the subcritical bone loss of 13.5%. But two things need to be noted: that one, the study was on MRI base, and second is that it was a very high demand population because this was carried out at an army medical center where we are looking at extremely high demand potential candidates who are involved in that study. So when we see a patient in our outpatients, how do we quantify? Well, you need to look at the warning size. We all know that your eyes will see what your mind knows. So if there are multiple dislocations, especially if the first incident is traumatic and then following incidents are with trivial loading, and if the shoulder is dislocating, you're probably thinking about a bone loss. Sleep dislocations, because none of the dynamic restraints are then functional. When you're looking at the mid-range instability, that means when you're doing the apprehension test, classically you would do it in a position of athletic function, that is 90-degree abduction and external rotation. Here you're doing it at around 45-degree abduction and look for sense of apprehension. In cases of failed procedure which are up for revision, why did the primary procedure fail? And that's when you need to contemplate bone loss. And on clinical examination, if there is an audible or palpable crepitus or clunk, that is a no-brainer that you're probably looking at bone loss. When a patient comes in, I guess most of us would offer a AP X-ray and a lateral X-ray, but then are these enough? And this is where the concept of true AP versus conventional AP comes into picture. When you're looking at true AP, there is effectively an overlap between the glenoid margins and the humeral head. So it really does not allow proper assessment of the glenohumeral joint. But if you're getting a true Grashe view where the 45-degree inclination along the plane of the scapula, this does not have any overlap of the glenoid and the humerus and makes evaluation of the glenohumeral joint easier. So when we are looking at a patient on true AP, you can see that you have the double cortical sign. That means you have a dense sclerotic line which is along the anterior-inferior part. As opposed to that, in a patient who presents with bone loss, you can see that the dense sclerotic line is present on the superior aspect because both the cortices are superimposing. But when you're looking at the anterior-inferior portion, the sclerosis has disappeared because you don't have two cortices, and this is the loss of double sclerotic line or double cortical sign. If you're looking at plain X-rays, and this is for those people where CT might not be available or there are massive financial constraints, that's where you can think about the Bernagio view. Now, I routinely don't do this, but it's a worthwhile view. And how do we do this view? It's simply because the beam is at 30 degrees to the horizontal. The patient is asked to keep his hand in an overhead position, and the X-ray plate is kept along the torso, and you have a shoot through. What you're supposed to look for is that if I were to describe this picture, on the superior part, you're looking at the circumference of the humeral head. The triangular portion that you're seeing is is the face of the glenoid. And in that triangular portion, the black arrows which are marked, that is the anterior rim, and that's the dense sclerotic triangle that you need to see. So if you see a few examples, you always need to get the contralateral side to compare. So if you look at figure A, you can see that the dense sclerotic triangle on the anterior aspect is very well visible. As opposed to that, here you can see a bony fragment which can be marked with the black arrows. Likewise, on the B image, you can see that the entire circumference of the glenoid is seen in totality, whereas on figure A, you can see a cutoff which is there, the so-called cliff sign, where there is a sharp cutoff to the margin of the glenoid. Sugaya further modified this view as the modified Bernagio view, where also known as the watching the TV in a sleeping position view, where it's easier to do this view as compared to a Bernagio view, but the principle remains the same, that you're looking at the anterior aspect. But what remains the gold standard is a 3D CT scan. So what you need to understand is whenever you're getting a 3D CT scan, there are two ways how you can quantify these lesions. Either you have the linear method where you're trying to take measurements along the face of the glenoid, or you have the surface area method by posing a circle along the anterior inferior portion or the inferior margin of the glenoid. You calculate the area of glenoid bone loss by various formulae. So in principle, you're going to request your technician or your radiologist to get you a 3D CT scan with an on-face view, which allows you to see the entire glenoid in its face. Now remember, this can be done on a 2D CT, but your gantry needs to... Hello? Right, your gantry needs to be absolutely in the same plane so that there's no superimposition of the humeral head. When you can get that, then the inferior aspect can be modeled on a circle, and then you try to calculate the bone loss by various formulae. Sugaya had explained the so-called circle method, where the surface area of the osseous fragment was then calculated. You can do the same thing arthroscopically, where you're using the bare spot as a reference mark and you're calculating your diameters. And again, the percent bone loss is calculated by a formula. However, Matt Provencia and co-workers have shown that this is not a reliable method because the variable here remains the position of your posterior portal. Because the glenoid is not a classical circle, if there is variation in the posterior portal placement, it need not necessarily give you accurate measurements, and that's the reason why this might not be as reliable as what was thought earlier. What we do routinely at our center is according to the Moon Shoulder Study Group, where we take contralateral measurements of the opposite side and we get both 2D CT as well as 3D CT measurements. It's pretty simple that in a non-involved shoulder, you take the maximum AP dimension of a normal shoulder, you take the maximum AP dimension of the affected shoulder, and the bone loss is calculated as A minus B upon A into 100, which is shown as a percentage bone loss. The same thing can be applicable to find out a fragment, if at all there is a bony fragment involved, which allows you to take your decision whether you want to fix it, whether you want to discard it, and so on and so forth. These are the various techniques which are available for calculation of bone loss when it comes to the glenoid. Again, I'm not going to go into detail into each one because I think Karthik is going to talk about the current consensus that which is the best method. So we'll leave it to his discretion as to which he finds, according to literature, as the best method. If you look at a couple of examples, why true AP is so important. Here we have a 26-year-old male presented with a road traffic accident around a week back, sense of dislocation followed by spontaneous reduction. He comes 1 week down the line with a shoulder sling back. If you pay careful attention, you can see along the anterior inferior portion, there is a superimposed image which is there, or there is loss of the normal contour rather. We went ahead and got CT scans done for him. His on-face view showed a significant traumatic glenoid bone loss with a fracture fragment. We took him up for arthroscopy, and these are his arthroscopy findings. That's the fracture hematoma with the fragment attached or hinging along the inferior aspect, cleared off the hematoma, and that's the defect which was there. We went ahead and did an arthroscopic repair for him. At 1 year follow-up, that is his incorporation of the fragment, allowing him to do all routine activities as a recreational sports person. If you look at your clinical instincts on history, that's something very important. Here we have this 42-year-old male, history of post-traumatic recurrent dislocation. On history, more than 30 episodes of dislocation, clinically mid-range instability. This was something which was done very early in my practice. At that point of time, a regular conventional AP was done, not a true AP. But here you see that on 3D CT, there was a fracture of the coracoid and a very small fragment which was present along the anterior inferior aspect of the glenoid. I was hoping for a glenoid bone loss, but the radiologist said that no, on this view, this is all that we can see. And then when you request for an on-face view, you can see that there is significant bone loss out there, and this is not amenable to an arthroscopic procedure. He went ahead and did a conventional French type of Gilles Walsh technique, Latarjet, and he was back to full function. What about the humeral side? I think Vivek is going to talk in detail about the Hill-Sachs lesion, so I'm going to skip that at this point. But what we need to understand is that the glenoid loss is not a solitary loss. You always have a concomitant humeral loss, and that would have the concept of bipolar bone loss. It has been described by Giovanni, Itoy, and Burkhardt. I have been fortunate enough to interact with all three of these gentlemen, and their understanding is simply phenomenal. What understanding of what concept they had given was still according to the 25% bone loss, but this is not something that at least I practice in routine day-to-day clinical setting. This is my algorithm that I follow, which is according to the Friedman's paper, where less than 13.5% bone loss, I really don't bother about the bone loss. I would do a standard arthroscopic procedure. If it's between 13.5 and 20, then I look at an on-track or an off-track lesion. If the Hill-Sachs is on track, I'll do a Bankart with a remplissage. If it is off-track, that's when I would do a remplissage, sorry. If it is on track, I would just do a Bankart repair. When it is more than 20%, I'm already biased towards the lethargy. 25 to 40%, I would think about a lethargy. If it's more than 40%, that's when I would probably think about an iliac crest or an Eden-Ebenet type of procedure. So in summary, identification of high-risk patients is critical. 3D CT scan, according to literature, still remains the gold standard in quantifying glenoid bone loss. You need to understand the concept of bipolar bone loss. You just can't look at the glenoid. You need to pay attention to the humerus as well. When you're suspecting bone loss, you should order a 3D CT as a routine. And there are many variables, not just the glenoid bone loss, which determine the outcome of a successful procedure. Thank you.
Thank you, Nilesh, for the wonderful talk. And now the paper is open for discussion. And the panelists can ask any questions to Dr. Nilesh. Now.
There is no accuracy on MRI, Nilesh?
So there are papers.
Radiologists, they say it works equally well with the CT.
So again, if you look at the Friedman paper, it's a clinical review paper, 2017 publication, which spoke about comparing also MRI and CT. They still talk about 3D CT as the gold standard. There are 3D MRIs, and I'm sure Aditya is going to throw some light on that. There are 3D MRIs which are now coming into vogue. There is not much of a statistical difference between 3D MRI and the 3D CT. The only advantage being that there is no radiation, of course, on a 3D MRI. But in 2 dimensions, I think they tend to over-quantify or under-quantify the lesions. Aditya, if you're on, if you could just share your thoughts on the same.
Yeah, personally, we have been using MR to quantify bone loss for a long time. I think the key things that we need to remember with this are that unlike CT, where you have a 3D data set which you can remodel in any which way you want, so you can change the angles, with MR, that acquisition of the angle comes standard. There are obviously 3D MR techniques, but everything comes at a cost in MR. So if you go with the 3D MR technique, you may lose resolution somewhere else. But what I will show you is some things that we have been doing and in my talk, I'll show you some ways in which we've been exploring bone loss and also my philosophy on bone loss. I mean, one of the big things that I get into is that everyone has 500 different methods, as is true of shoulder surgery, that if you are a self-respecting shoulder surgeon, you must have your own method of calculating everything and you must name it, because otherwise there is no point in being a shoulder surgeon. I'm just joking. but the point of the matter really is that we are looking for large changes. Like we are looking to categorize people into less than 15%, 15 to 20%, 20 to 30%, and more than 30%, because our management changes at those block levels. And if we change, no matter what method of calculation we use, we are not really going to error too much in putting them in those categories. So I still believe that we must simplify this. We keep tending to overcomplicate this by using more and more and more methods. We should realize what the primary decision points are for us and how best we can identify those in a simple way rather than creating more and more complicated things.
I completely agree that, see, for me, whether it's 18% or 19% is not really going to make much of a difference. But definitely if it's 18% in a housewife who's probably not going to do too much of overhead activities as opposed to a wrestler, the logistics change completely. It's a no-brainer for me.
Absolutely.
So that's why I said that bone loss is not the only variable.
Correct.
Demand of the patient and what he is presenting, I think that adds on to a lot of information when it comes to decision making.
Yes.
There is a question from Dr. A.S. Rao. This is regarding any universal method to quantify glenoid bone loss on plain CT, axial and coronal section. So do you have a single technique which can be used in clinical practice, so as to get the exact the coronal axial.
I'll show you that in my talk, at least what I use.
Okay. Okay. So now I have a question for Nilesh. Nilesh, you spoke about two studies. That's by Dr. Itoye, and second, I think, similar pattern study which were done by Dr. Sekia. And both these studies where they calculated instability were done on cadavers. So cadaveric study which has been done and reciprocation of those same cadaveric study in clinical practice for instability, which is a a little bit tricky pattern where you have a lot of factors: the bone, muscle, ligaments, tendon. So you think there is a little bit of margin of error at the level of study itself when they 25%.
Absolutely. See, this is not a single variable that we are looking at. Although the stock was a single talk, but when you're looking at instability, you're not looking at a single variable. If you were to think about this and apply John Tookish principle of subclinical bone loss of 13.5% in every patient of ours, it becomes a big challenge. It's practically not possible. And yes, most of these are cadaveric studies. And again, it's impossible for us to kind of maintain the same kind of control, because your dynamic restraints are going to be different than my dynamic restraints. Your humeral involvement is going to be different than my humeral involvement. But this is the data that we have at present. And there is no single factor which can determine and that's why I said we are yet to find the holy grail, because that is the holy grail. We don't know how much bone loss is true subcritical bone loss.
Nilesh.
Yes, sir.
Yeah, I want to ask you, like radiologist gives us the bone loss is of almost 15%. And how much times you do arthroscopic assessment and you find out that it's more than 20%?
Okay, fortunately, I mean, there might be a bias. The team that I work with here, and Aditya knows this, and we are blessed to have amazing radiologists. I mean, very rarely has there been a massive error in calculation. I'll be very honest to that. But everyone might not be.
But you do arthroscopic assessment in all your patients for glenoid bone loss? You calculate it on table?
No, I don't. So my decision whether to do a bony procedure or an arthroscopic procedure is something which is pre-op, is not something which is intra-op. I remember once, and this is in a teaching medical college, that I had gone in and I had seen that there's a huge void, and I aborted the procedure, and I posted in the next day, of course, for consent reason, to do a bony procedure. Having said that, the same does not hold good for remplissage. Many times I think about doing a remplissage, but I don't feel the need to do a remplissage. So what I used to do earlier, like most of us would put in the anchor, take the bites, not tie it. What I typically do now in routine practice is I do the Bankart, and after doing the Bankart from the anterior superior portal, if I can still see the heel sacs, only then I do a remplissage. Otherwise, I don't do a remplissage.
Okay, now because now Walter and Burkhardt here, they have come up with the paper saying that arthroscopic assessment is also more important as compared to like what we get from the 3D CTs for the off-track, on-track lesions. Because most of the time on-track, off-track lesion done on 3D CT scan is not reliable. Because as you said, you need perfection.
True. And that's the reason why I said my remplissage indications might be variable on arthroscopy findings, but my bone block procedure, I don't think so. Bony procedures, I decide pre-operative which way I'm going to go.
Dr. Raman.
Samir, the thing is that the question you are asking for about the on-track and off-track, but when we do the CT scan, we can jolly well say that whether it is on-track and off-track. And I think completely agree with Nilesh that we take the decision whether we are going to do it arthroscopic, Bankart and remplissage, or the bony procedure to do it pre-op. I think it is most of the time with more than 99% accuracy, we can say from the CT scan, we can tell whether it is going to be a on-track or off-track.
Exactly, sir. Sir, if it's more than 20% or near to 18-20%, we are sure. But sometimes I have come across the cases where we go inside arthroscopically and we do the assessment, because my residents now, they are trained as if when we go inside, I tell them, looking at the glenoid and measuring with the scale, I tell them the diameters. Within 5 minutes, they calculate and tell us how much is the arthroscopic assessment as such. And then we just try to compare it.
Yeah, there is a question from Dr. Raman Khan and then Dr. Nagaraj Shetty.
Hi, Nilesh.
Hi, good afternoon.
Hi, Nilesh. What is the reason that you shifted? I mean, I met Itoi in the conference held by you. He was your guest.
Right.
And since my discussion with Itoi, I have not changed the practice. Itoi is a researcher and he categorically said that the critical bone loss is 25%. Of course, it included the slides you showed, and very important fact you brought out that the bone loss has to be oblique.
Yes.
If it is only a horizontal or a vertical bone loss, it may not amount to the same amount of instability. But if it is oblique, going from 3 o'clock to 6 o'clock in an oblique fashion along the long axis of the glenoid, which is slightly tilted anteriorly and cranially, then of course you are looking at an instability. And in that way, if it is 25%, it still remains the critical bone loss. So what was your view of changing from 25% to going to Turkish paper and then coming to the Friedman study? And why did you shift your critical bone loss?
So I think 25% bone loss still remains. If you're doing a 25%, if you're going to follow the 25% ballpark, many times you have to do an adjunct procedure to them. That means you have to add an remplissage.
Yeah.
We in fact, so I think Vivek's paper is also there, but we had also published this that with remplissage, of course, in abduction external rotation, it is going to cause loss of movement. In neutral position, it does not cause any loss of movement. So this concept, so even now, when it comes to, it depends on the patient profile. If you're looking at someone who's going to take his hand up.
Yes. So yeah, I absolutely agree. And there I come that we debate too much about the criticality of the bone loss or subcriticality of the bone loss. But actually, the success doesn't depend on that. Say if you're choosing a procedure, say at around 19% or 20% bone loss, and you've gone ahead to do an arthroscopic Bankart, and in addition, maybe a remplissage if it is an off track, or even if for your additional security, which I do quite often, that if bone loss on the glenoid side is increasing, even if the lesion is on track, I might do still a remplissage depending on the location of the Hill Sacs lesion. If it is more medial, I will not hesitate to do a remplissage even if it is not significant bone loss. So the critical factor becomes the patient factors, not the glenoid bone loss and the other things. So, and I mean, we will keep on debating this, but yes, I mean, the studies have gone down so much that in France, you will get letter J, even if you are 19 years old with 2 dislocations, if you are in a competitive sport. And, America is catching up and arthroletargy is catching up. So scale is tilting more towards letter J again and bringing it down. But if you look at the Glenohumeral study from Italy, and he's produced this on track, off track glenoid bone loss and the Hill Sacs lesion, and he's built it into the injury severity score, and he's produced his own score to avoid unnecessary lateral J procedures. I think that's a paper we should be looking at in detail eventually going into the future.
Yeah, thank you. Nagaraj, you have a question?
Yes, I have a question to Nilesh. Hi, Nilesh. Good presentation. And also to Aditya, if you could chip in. The question is on the patients who are having higher bone loss in the range of 30% plus, wherein your confusion is versus a Latarjet versus an ICBG. And there is the congruent arc modification, which comes somewhere in the middle because it gives you that extra articular arc. So for these patients, have you, Nilesh, started measuring the coracoid dimensions? What have you found? And have you found that the thickness of the coracoid in our patients has helped you to do the congruent arc? And Aditya can chip in if he's got the measurements for our population.
So I'll start off first, and then probably Aditya can add on. So yes. I had first learned the Walsh technique. I went on to the congruent arc. I probably must have done around 4 or 5 congruent arcs, and I came back to the Walsh technique for 2 reasons. One is that the thickness of the graft is something which becomes quite narrow, and you're always worried. Also, I'll submit that at that point of time, I was either using the 4.5 malleolar screws, or I was using the 4.5 AO cannulated cortical system, right? Cannulated screws. And these require a 3.2 mm drill, which really got me worried. That fortunately, I've never had a fracture, but that really got me worried. And I think, again, Matt Provencher has shown this, that the surface area for a congruent arc, although biomechanically more sound, is a lesser surface area even for healing and incorporation of the graft. And that's why a Walsh technique might be preferred. I am a complete Walsh technique guy. I do all my Latarjes by that technique. Coming to the second question, that in an edinhabinate or an iliac crest graft, how many times do you have to do it? Very rare. I've done it less than, again, 5 times. And that is when I have seen a bone loss of more than 40%, out of which 2 were epileptics. One was actually a meshed anterior dislocation where the head was dislocated, an elderly female with a cuff tear for whom I did a reverse later. So fortunately, I think the indications are very, very limited here. We don't measure our coracoids routinely, but yes, it would be a worthwhile thing. I know few surgeons who measure their coracoids routinely, preoperatively, the thickness wise as well as length wise.
Thanks, Nilesh. So I think that's an important point I wanted to mention. You know, the thickness of the coracoid, although we talk about congruent arc, I agree with you. It's always intimidating that you are going to shatter that bone off. And that thickness is not good enough for our patients for even the 3.75 screws. 4 mm definitely is very intimidating. If Aditya can tell us if he's measured these and what are the measurements in our population average, can we still consider the congruent arc?
Yeah, so Nagaraj, we've not really been asked to measure them very often. I think one of the things that I, have had discussions about and what people question is that when we do end up doing the measurements, whether we should do them on CT or MR, because one of the things is you're not harvesting the entire coracoid. You can only go as far in the coracoid as where the anterior aspect of the trapezoid ligament attaches. So you don't want to go further posterior to that. On MR, one could potentially identify that spot as well. And you could say that, there's only this much coracoid anterior to that. But unfortunately, I've never been really, the big things that we make it a point of is if we see a coracoid fracture, we definitely mention it. And there are a handful of cases in which that has happened. But the number of times we've specifically been asked to measure the coracoid and that being an issue in terms of management has been small. I think for the most part, the surgeons that we deal with, if they look at somebody and they say, look, this is definitely a 30, I think many people would, I think in terms of from what little I understand about orthopedic surgery is, you have, the regular type of Latarjet procedure you do, and a second one where you flip the graft and you put that in, which sort of helps you with a little bit more bone than the other one. And I think in most cases, if up to 30% loss, you can get away with just flipping the graft. But in those who you suspect more than 30% loss, then you might as well go for an iliac crest harvesting. But that's,
Nagaraj, I would like to add, Nagaraj.
Yes, Dr. Samir.
Can I just come in for a minute?
Yeah, quickly, because we have to move on. We
have published a paper measuring the coracoid thickness in Indian population on cadavers, on 70 cadaveric scapulae. And we found that the thickness is significantly less. It's more often than not, you'll end up actually having less than 1 millimeter of bone on either side if you use a 3.4 or a 4 mm screw. It's mostly 6 mm. It's not even 7 mm. So if it is 6 and if you're using a 4 mm screw, you'll end up having only 1 millimeter on either side, which is very dangerous and scary. So and we recommended that we don't perform this. Flipping the graft very often. Not to do that, unless there is a clear indication, unless the coracoid graft. So we recommend actually measuring the coracoid thickness intraoperatively using a caliper in all the patients, and we just published it in IJO this month.
Good.
Yeah, Nagaraj, as we are doing arthroscopic Latarjet, we have come across your point is valid. Like if you see the length of the coracoid, it's slightly rotated also. So it's difficult to calculate the length on CT and MRI. So what we are doing now, our radiologists, they are giving us a fair idea of the length, like 22 mm if it is there. Then we go ahead with the arthroscopic Latarjet, and width, if you'll see, as he said, it's almost 7 mm or 6 mm in all our average Indian patients. So now Depumitec has come up with the instruments which we are having the distance between the 2 screws is less, because there we are putting the 2 screws, but the distance is less. Now what we are having the Depumitec Zig for that. So this is very important thing when we are doing arthroscopic Latarjet, and we measure every time on the CT and MRIs for this.
So it's safe to say that congruent arc in our population, we need to be very careful. That's what I basically wanted to.
Yes.
Thank you, everyone. So we'll move on to the last question by Dr. Gaurav. Gaurav, do you want to ask question or next talk? Gaurav? He was
Yeah, I wanted to ask something.
quickly, Gaurav. Yes.
Yeah, just a quick one. So you have cases where you've got this bony bankards, right? And
Yes.
then you come across, say, for argument's sake, you come across, you do your measurements and you figure out that you've got something like 18%. So what decision would you make in these? That's for Dr. Nilesh.
Yeah, there's a malunited bony bankard. What your question is? Gaurav?
Sorry, say again.
Gaurav, I can't hear you. What your question for a bony bankard? Is it a malunited bony bankard?
Yes.
So you mean to say, do I disregard that fragment or do I incorporate that fragment? That's what your question is, correct?
Would you attempt? I'll just stop my video. So, am I audible now?
Yeah,
Yeah,
that's better.
please go ahead.
That's better.
Yeah. So an old bony bankards, would you attempt to bring it up to make up for your bone loss, or would you disregard it and then go ahead and do a bony procedure?
So I'm not going to sound very idealistic. Most of the times I would disregard it and I would go ahead with a bony procedure. It's only in an acute setting where I know that within 6 weeks, 8 weeks, if the patient is coming and I can redefine the fracture line, that's when I'm going to elevate that fragment and do a bony bankard repair.
Okay. Vivek, can we go ahead with your talk, Vivek, on the humeral bone loss? Rajkumar?
Yes, I think we'll invite Dr. Vivek. Thank you, Nilesh, for this wonderful discussion on glenoid bone loss.
Thank you, sir.
I now call upon Dr. Vivek Pandey to give his lecture on bone loss in the humeral head and its influence on glenohumeral instability. Over to you, Vivek.
Thank you, sir. Let me just, looks like there is some problem. Just a second, there is some problem. The system is hung. Am I audible?
Yeah, you're audible, but we can't see your screen. Vivek.
No, I don't know. My system is suddenly stuck. Just give me 2 minutes. Otherwise, what you do, you can ask.
We'll go ahead with Aditya's talk and then.
Yeah. Because I need to shut down this and come back again.
Yes.
I think it's stuck. Okay.
Aditya, if you could start your presentation, Dr. Aditya.
You just need to give me screen share access.
Sandeep?
Yeah. I don't know. The whole thing is stuck.
Okay, take your time, no problem.
Okay, I got this. Vivek, take care. See you soon. Okay,
Yeah.
All right. So this is a bit on glenohumeral bone
I'm
loss.
just logging out for a while and then come back. Sorry.
Okay, so this is a bit on glenohumeral bone loss, how I do it. Oh, sorry. Can you see my screen?
Yeah, we can see.
Okay, great. So what I'm going to talk about is some basic measurement and reconfirmation. And here I think, the important things about how we measure and what is important to me when I'm measuring things and what comes back to bite me. And because I work closely with the surgeons and they're happy to bite. So I'm happy to take those bitings because they've been helpful in learning. And then look at sort of how that fits into the clinical relevance of what's happening in the practice around me. So in terms of measurement, I would start with talking about MR measurement because most patients who have instability end up starting out with an MRI. And so my goal over here always is to try and figure out on MR how we can give you the most amount of information. As a default in our center, when we're imaging, what we end up doing is we ask our technologists, or we have trained them to take the sagittal images always running parallel to the glenoid surface. Okay, they're not always right, but most of the time they've been doing it. So we ask them typically to go towards the center of the glenoid, to take the axial image, to take the axial image of the center of the glenoid, to take the coronal image, the central coronal image, and then based on that, we'll get an image that is clearly an en face glenoid. So the first thing we want to do is I check obliquity when I'm looking at these patients. The next thing that I do is I look at the posterior inferior quadrant of the glenoid, and I usually try to match my circle. I use the circle method, and I usually try to match my circle to the posterior inferior quadrant of the glenoid. When it comes to marking out where the anterior margin of the glenoid is, I use the axial images, and then I use what's a triangulation feature. So in other words, if I double click on this point on MR, wherever the anterior most margin of the articular glenoid is, it will show me that same spot on the glenoid on the sagittal images. So it gives me a clear idea as to where exactly that margin of bone is. So once I've identified where I'm going to draw my circle and where the point of glenoid bone loss is, then so I check these 2 points, and then I draw the circle and I essentially measure the bone loss from that. So in this case, for example, 4.3 divided by 29 millimeters, which is about a 14% bone loss. So again, here the key thing that I find is that we must make sure that we have the right obliquity, so we are seeing the glenoid on face. Now, if I don't have an image, so like this case here, you can see here that the glenoid is off far. It's like, it's a little bit oblique to the axis of the sagittal plane. And similarly here on the coronal plane, this should probably have been, let me just draw that out actually. So ideally, this line should have been running in this direction, but it's running a little cross to that. And ideally, this vertical line should have been running a little bit in this direction, and it's running a little bit cross to that. So therefore, we're getting a really odd looking glenoid diameter, and then that makes the glenoid look really funny, and then you're slicing through and you're not really getting the best image out of this. But even in those cases, I find that all is not lost. What I've been toying with lately, and I found actually reasonably helpful, is that I tend to draw a line that is parallel to the glenoid articular surface on the axial images. And then I draw a line that goes along the anterior cortex of the glenoid or the scapula. And I project that line to where the articular surface is. And I measure this as the bone loss. And I tend to measure this, 1 or 2 slices above and below the equator, come a little bit up and down to try and see where I see this maximally off and if there's a pattern in it, because essentially that's what gives you the area of glenoid bone loss. So in this case, for example, you can see it's about, 3.2 millimeters out of 24. So it's about a 15% glenoid bone loss. And when you start to look at these, and I've just worked on, I've not published anything on this, but when you start to look at this, you start to compare better done images, I find that this value works out to be reasonably good. Where this can obviously run into challenges is when you get into the far inferior glenoid or into other areas, but I'm still working on that. So I find this is one way you can salvage information from the MR. At least you can say that this person definitely does not have, significant bone loss, and perhaps therefore you should don't need to do a CT. But obviously, if you have a patient who's dislocating multiple times, etc., then the default is to go for a CT. Now, when doing a CT, again, I think the biggest things for everyone to focus on are getting the plane right. Irrespective of what method you use, you need to get the plane right. And in order to get the plane right, this is typically what a normal shoulder would be, and these would be the typical axial and coronal planes that you would get by default. These are just orthogonal axial and coronal, orthogonal sagittal and coronal planes. So the first thing you need to do is you need to rotate the plane so that it runs parallel to the glenoid at the level of the mid glenoid. So on the axial images, and this starts to give you some sense of what the glenoid surface is going to be. The second thing that we end up doing is we end up tilting the coronal image plane also so that it is parallel to the glenoid. So it's not entirely straight, it's slightly tilted. And then this will give you a proper idea of what the on-face glenoid is at the glenoid articular surface. Once we get that, I sort of look and try to find the central sclerotic area, and the center of the central sclerotic area usually corresponds to the bare area on the glenoid, and that often is sort of a decent marker for the central area of the central point of the glenoid. I do the same thing with an MR, so I'll mark out the posterior inferior quadrant. I'll draw a circle that surrounds that area that covers a best fit circle essentially. And then I'll do the same thing that I did the MR. I'll try and mark out the anterior most margin of where bone ends at the articular surface. I'll correspond the spot on the sagittal image. And then from using that, I will calculate the glenoid bone loss. Sometimes we want to, you find that you're not getting the answer. You get an answer that's very small, and the clinical scenario suggests that there would be larger bone loss. So in those situations, obviously, we also, and even in all other situations, I tend to look at things in 3 ways. I look at the axials, I look at the oblique sagittal, that is the on-face sagittal, and then I look at the 3D image. Now, when you look at the 3D image, I think the important things to remember are when you get 3D images, they're given to you in different obliquities. So what you want to do is you want to identify which the correct obliquity is. Now, if you look at this leftmost image here, it is obviously abnormal. This is too oblique for us to look at it, and it may not give us the right sense of the amount of bone loss. But when we look at these two, we're sort of stuck between a rock and a hard place as to, well, should I choose this image or should I choose this image? And in that situation, I basically say we're dealing with Covishield or Covaxin, whichever one you want. It boils down to a little bit of individual choice with this, realizing that the human body and all these things are, when we think of even measuring bone loss, we measure bone loss in millimeters. And it is possible for anybody to miss a millimeter here and there. And if on the basis of that, you're going to say somebody goes from 18% to 19%, and that's going to change your management, then that's something we should be questioning very seriously. And then, of course, the image on the left is actually coronal. So let's not even go into that one. So ignore the obvious. If you're getting close enough, I think is my dictum is accept what seems close enough to the appropriate obliquity. Also, when you're drawing your circles on the 3D images, remember to look at the bone margins. So for example, here it's very clear that this is actually that remodeled bone or that healed bony Bankart, whereas this here is actually the margin of the glenoid. So when you draw your circle, remember to measure the margin of bone loss to this part of the glenoid and not to this area over here. So that will tell you that is the bone loss. And something similar over here. This is excessive bone outside or remodeled bone, whereas this thing is actually the residual bone margin. And on basis of this, you would know that the bone loss is actually in this area. So at the end of this process, you're trying to generate the estimated normal glenoid diameter, the estimated glenoid bone loss, the residual glenoid bone diameter, and the glenoid tract, which is 83% of the estimated residual glenoid diameter. What is the best method of estimation? As we discussed a bit earlier, we need to create large blocks of data. Less than 15% will probably get arthroscopic, 15 to 20% will be in that subcritical category where arthroscopy, but maybe a Latarjet depending on patient demand. 20 to 30% is definitely critical. You would do a Latarjet. And then, I'll leave it up to your individual choices as to whether you want to flip the graft, don't want to flip the graft, and whatever else you want to do. And then more than 30% is excessive. You're going to think of whether you're going to use a larger graft, iliac crest, etc. So irrespective of the method used for measurement, as long as the measurement is made on the correct section in the correct obliquity, you would get a ballpark sense, even by looking at something visually, on which categories these things fall in. So, that's at least my dictum on looking at this. And that seems to have worked pretty well. My surgeons haven't shot me yet. And they're not hesitant to shoot me either. So I feel reasonably confident of that. In terms of measuring the Hill-Sachs lesion, one of the things I try to do is I try to make sure that we're measuring along the length of the humeral shaft. I try to ensure two things. One is that we're not measuring too far down, because there's a typical posterior humeral head bump that happens if you measure lower or towards the center of the humeral head. So you got to go towards the upper aspect of the humeral head, and that's where you're going to find the Hill-Sachs lesion. So you can see that over here. And that essentially is the measurement that you're going to take as the width of your Hill-Sachs lesion as to when you're measuring the glenoid, when you're measuring the humeral tract. On MR, I think what you do is you tend to look at all the images on the sagittals. You try to identify the uppermost sections where you start to see some variation or you see some flattening of the humeral head. And then you try to find a corresponding axial image where you see that flattening, on the glenoid. And you find two of these images sometimes. You'll find one here and then one more here. And then again, between these two, Covaxin versus, Covishield, you decide on which of these two. And typically you'll find that the measurements are not very off. The key measurement, obviously, that you want to remember is you want to measure till the footprint or till the sort of the medial most aspect of the infraspinatus footprint. So you want to include the Hill-Sachs lesion and a little bit more till the infraspinatus footprint. So you get a total sense of the actual amount of bone that is affected in this. And at the end of this procedure, you will have the Hill-Sachs width or the glenoid tract that will help you. So my process is typically that I assess the glenoid bone loss on MRI. I look for the obliquity, is it right or not? Can I estimate it reliably on axials? And then is this going to matter for planning in this particular patient? If I'm not confident based on that, then we'll look at assessing the glenoid bone loss on CT. And is the obliquity all right again? Does the oblique sagittal make sense? And I compare it with the 3D reconstructed image to further confirm what I'm trying to identify. Subsequent to that, I'll get the glenoid measurements, which will be the glenoid bone loss percentage-wise, as well as the glenoid bone tract, the glenoid tract. And then I'll assess the Hill Sacs on the CT or MRI. Again, I'll go back to look to see if I've picked the correct slice, and I'll identify what is the glenoid tract. And then finally, I will have answers that are what is the percent glenoid bone loss here, and whether this is engaging or non-engaging or in the borderline category. And how will this all end up mattering? Based on the glenoid bone loss, we've characterized them into the various groups. We want to see the Hill Sacs. We'll characterize them as small, moderate, large. We look at the status of engagement, whether it's yes, no, or borderline. We look at the patient themselves. Is it a low demand, moderate demand, high demand, as an epileptic person with a high volume? And then based on that, you'll make choices on your surgical options as you want to do a labral reconstruction, a tatarge, a larger bone glenoid augmentation, a remplissage, or a combination of everything else. So that's sort of where my understanding of glenoid bone loss and how I approach it as a radiologist, and I work with orthopedic surgeons on it. Hopefully it gives you some sense of what I think is practical and applicable in the clinical setting, as well as at practice, because oftentimes we find ourselves driven down into a lot of minutiae where we're not really making that much of a difference. And I think that's where we have to start questioning ourselves as to how much minutiae we dive into and what is the gain from diving into that additional minutiae, where essentially in diving into that minutiae, we are actually creating more variability, which could be far in excess of the problem that we're trying to solve. So I'll stop with that and be ready for any questions.
Thank you, Aditya, for your lucid presentation. The paper is open now for discussion. I'll now invite questions from the...
Can I ask a question to Aditya?
Yes.
Great presentation, Aditya, as always. There's no question of shooting you. You've done a great job in MSK. We all know that. The first is regarding the moon study or what Nilesh mentioned, what they follow in Pune of measuring the opposite side. And that has been pressed upon for quite a few years. So that is my first question. Why do you prefer our technique, which we follow here, compared to measuring the opposite side? And the second question is based on MRI versus CT. You being a competent radiologist, you have your ways of probably matching up your efficiency on MRI as you would on CT. But generally as an orthopedic surgeon, and generally what we have seen is that MRI underestimates the bone loss, which we would corroborate arthroscopically also. So therefore, as a surgeon, I would be more confident of a CT quantification. Please clarify these two things for us.
Yeah, so I think it's down to very simple stuff. So the first question again, Nagaraj, was about opposite side. Yeah, I think, and I've spoken to now a few of the surgeons in our city, and I think this is, like I said, this is, it's Covaxin or Covishield, I mean, whatever works for you. The bottom line is, can you reliably tell and put people into glenoid blocks? The issues with comparative sides are that if you get overly confident of the comparative side, I think people have demonstrated that there's a reasonable proportion of patients who have single unilateral instability who may have bilateral instability. So whether that comparison with the other side matters or not is an issue to be concerned. The second thing is, if we are trying to do things at work, what we are trying to do is we always want to try and maximize the information that we gain out of a study and not add an additional study. So it takes you down to the next part where you talk about MR versus CT. Now, when we've looked at MR versus CT, I think over the years, what I've been working on, and there's data out there, plenty of data out there that says MR is equally efficient, equally good as CT in detecting bone loss. But having said that, it's obviously important that the sections be taken correctly and that the radiologists understand what things are. Let me put it this way, to put it differently. There are certain surgeons who prefer to do certain procedures arthroscopically. There are certain surgeons who want to do them open. This is a matter of preference and comfort, right? If you are a person who's very comfortable arthroscopically, you will do it arthroscopically and your results are the same. If you are somebody who does it open and open works for you, but arthroscopy sucks for you, then you're going to say, wait a minute, arthroscopy is horrible, open surgery is good. So it's the same thing for us. When we look at it as a radiologist, say, I can give you the information with MR. I've tested it against my own population where I've got MRs and CTs. And the things that I do, whether it be trying to match up the anterior cortex on the other thing, whatever steps I take, using those steps, I'm able to be reasonably good. There are some times that I'm off, and I've realized those times that I'm off, and I take all the other steps. So if the story doesn't seem right, if the obliquity seems off, I don't hesitate to reach out to the next thing. I don't hesitate to say, let's get a CT also. But everything matches up. It looks at the CT, it says, look, this looks like very much between a 20 to 30% bone loss, definitely not below 20%, definitely not 30%. We're not changing any management by doing anything more here, then that's good enough. If somebody says, well, this looks like, I think this guy's got 40% bone loss, but your MR is finding 20% bone loss, then we say, wait a minute, if you have that kind of doubt, let's get a CT and let's just sort it out. We don't want to harm the patient in any possible way.
Yeah. There is one very important concept which has floated in last 5 years, on track and off track.
Yeah.
And in your presentation, you showed a wonderful measurement of calculation of glenoid loss, similarly on the Sacs side. So what is the clinical relevance, and how really a radiologist can reciprocate those off track, on track concept if one has to do it on MRI and CT scan? Because that is what is getting us more confused.
So there's data.
Do all radiologists follow off track, on track concept, or do they follow the other concepts?
No, I mean, I think you have to work with your radiologist. You ask. I think the problem with many orthopedic surgeons is you ask radiologists as if we are a single entity. We are the Borg and we think alike all the time. It's like saying every orthopedic surgeon has the same thought process. So if I put the same case to every orthopedic surgeon, they should give me the same answer. That's not true, right? I mean, that everyone has variability. So all I'm saying is, depending on what information you want and you need, we can give you that information. Currently, my practice asks of me to look for on track, off track. They ask of me to measure glenoid bone loss, and I do that. From whatever values we've measured on MR and whatever values we've measured on CT, people have been equally happy with both. So the trend in our practice is to say, let's just do the MR. We're happy with the MR if it fits with the clinical picture. If it's not fitting with the clinical picture, let's go ahead and do the CT at that stage. So that's sort of where we get. I'm not sure if I helped to clarify anything in that or not.
Not everyone is as good as you are. Sometimes tool with full is still full.
No, but I mean, I think the key thing over here actually is that we just need to speak more to each other. I have been fortunate to learn because I work with all of you.
Yeah.
And all of you, I don't hesitate to pick up the phone to speak to you, and you don't hesitate to pick up the phone to speak to me.
There is a
I think that needs to expand to more people.
So, can I say something?
Yeah. Quickly.
So the PICO method takes into consideration the contralateral glenoid, and historically and in the literature has been said that it's the most accurate method till so far. So whenever I get the CT, my radiologist, and Aditya must be knowing him, Sriram Rajan in Delhi. So he does the PICO method and Sugaya method for the ipsilateral glenoid and the contralateral glenoid, and he will give the percentages for both. I have not found a difference of more than 1 to 2% in both the methods over the last 5 years. So it practically doesn't make a difference. And I actually, it's a very good talk by Aditya that he is putting it into blocks, not into 16, 17, 18, 19. It's like, 15 to 20. And that's how the surgeon should be planning, because then the bone loss takes less precedence as compared to the patient factors, which is again the most important thing. Thank you so much for a great talk, Aditya.
Yeah,
thank you.
Nilesh?
Yeah, again, great talk. Just to point, very well taken, that yes, MRI is equally good, and you've shown in your hands. I've never had to complain whenever the reports have come from you. But just if I have to put it out in the open and ask you, what is the inter-user reliability of MR measurements and CT measurements amongst radiologists?
Yeah.
And without a bias, what would you say that, okay, 10 radiologists would get the same measurements on CT, but 10 radiologists might not get it on MRI, or vice versa?
Yeah, so I honestly, I cannot give you that answer because I don't know. So if you're looking for that, and that's where more the crux of the problem lies, right? The crux of the problem lies in inter-observer variability and also in what method somebody relies on. So I think if you looked at that, then you would obviously get much better consistency if you use CT, just because you would not be reliant on a technologist acquiring the images. You can change the obliquities, you can look at it at 3D, you can do a few more things with that data, and more people can access and do that and deal with that data than that one person. So if you wanted to do inter-observer variability on things, etc., you would be able to comfortably do it on CT. On MR, you're dependent on the scanning center. So for example, if you sent me an MR done at a different center differently, I would not be as good at telling you the bone loss as compared to if I did it at the center that I'm working at, because I know that's how my technologist does it. So I think that's the biggest thing.
Nilesh, I'm going to cover this in my talk about the inter-observer reliability in MRI.
So we have another question by Dr. Rajkumar. Rajkumar.
And sorry, just to give you one quick thing about inter-observer variability. As long as you have set, so for example, in our practice, we have set out the rules between us as a group of radiologists as to how we measure bone loss. So between us, we have very good inter-observer variability. In fact, I play around with myself all the time where I'll take an old scan and I'll remeasure it. And I did it for today's talk as well. I just took a scan that I randomly read years ago, and I remeasured the bone loss, and the bone loss that I measured again is actually the same. So not even off by 1% actually. So I find that it's very good. But if you look across, if you have different radiologists, the key thing is, I think, setting the rules right. So if everyone's following the same rules to mark the points, then you'll get the same answers. But everybody's not, then you probably won't.
Thank you, Aditya. The question is for both Nilesh and Aditya. We understand that you use the best fit circle method to assess bone loss on the glenoid. Is that correct?
Yeah.
So my radiologist uses the PICO method as well as the Moon study. So contralateral shoulder is also used.
Okay. Now, when we use the best fit method or the circle method, the anterior cortex and the posterior cortex of the glenoid probably are not at the same level. Is there a possibility that sometimes we can overestimate or underestimate the bone loss by this circle method?
I think you can I think there's one thing that I have seen oftentimes is that, or not oftentimes, but occasionally, is that you just have an abnormal glenoid morphology where the posterior glenoid just seems a lot more shallow. And that, irrespective of sort of the method that you use, you do end up being, a bit confounded by it. And I think there you sort of run into those issues where you start looking, some of the things that I'll do in those cases, I'll just look at the glenoid diameter to start with at a decent point and say, look, is this a flatter glenoid than usual in general? And I think that sort of, those are some of the situations where I wonder about. Now I don't have a great answer to it, but if I and that, your typical glenoid diameters are going to be in the, 3.5 centimeter sort of, range. So if you're finding that you're drawing a circle that looks much bigger than that or much smaller than that, then you know that you're probably over and underestimating it. That's, I think, the other thing that helps in terms of that.
Nilesh?
I think, one more thing is, I would completely agree with Aditya that the orthopedic surgeon needs to work in close association with the radiologist. I don't calculate my bone losses. I would just be sounding very unreal if I would tell you that I just get the scans and I calculate the bone loss. No, I don't do that. My radiologist does it for me. But yes, practically whenever I'm in doubt, it's just a phone call away. She's a good friend, so there's no issue at all. But I think the same thing needs to be extrapolated, and you can tell your radiologist what you need to look for. And because they do the same thing over and over again, their measurements are much, much more accurate than we doing a one-off case on one fine day because we want to show it to someone. Doesn't make sense.
So to summarize what Nilesh and Aditya said, you always have to work hand in glove with the radiologist to have the best measurements on the glenoid as well as on the Sac side. And there is no last word said on how the bone loss has to be measured. It may be different for different people, but always stick to the most normal measurements or the most found measurements in managing your patients. Roshan, is that correct in summarizing this?
Yes, please go ahead. We can start Vivek's talk now.
Yes, Vivek. Thank you, Nilesh and Aditya. Wonderful talks. Thank you.
Thank you.
Vivek, your screen can be seen. You can proceed.
Perfect. Okay. Am I audible also?
You are.
Okay, perfect. Sorry for the confusion. I think my computer got stuck. And it happens for the good, because I think Nilesh and Aditya, they have already summarized almost everything. So I just need to quickly rush. And right in the beginning, let me tell you, it's a long journey of assessment of Hill-Sachs lesion. X-rays and this and that, CT, 2D CT, 3D CT. But at the end, I think if this talk I would have given probably 12 years back, it would have been very difficult to say that what exactly the Hill-Sachs job is. Where is it? It is like Shadi mein Fufa ka role. You don't know where is he? Is it the bride most important or bridegroom? But then at the end you realize it's one of the key thing. And probably the paper of Itoi and Yamamoto changed the entire scenario where the Hill-Sachs stands today. And probably for last 12 years, everybody's roaming around only that concept of off-track and on-track, and that's what giving us a large part of guidance. But it's nice to see actually that there are so many things in Hill-Sachs to see and assess, and then to probably make a decision. We all have seen various types of Hill-Sachs, from a situation where you have absolutely no Hill-Sachs lesion or a very minimal to probably mild to moderate, and coming to a large Hill-Sachs lesions. It's a compression fraction on posterolateral aspect of humeral head. Almost all of us know. It's almost in 40 to 90% of acute cases we do see, and it's almost 100% in traumatic recurrent dislocations. I'm not talking about the Ambry cases. Its role in anterior stability, instability has been debated for a very long time. People kept on coming with a lot of X-rays, this view, that indices, but everybody stopped somewhere at indices. Everybody said that it has an association, but the decision making was one of the most difficult aspect of the entire Hill-Sachs pathology. It was very early reported by Malging in 1855, but it was later the radiologist Harold Hill and Maurice David Sacs in 1940 who came up with this Hill-Sachs lesion. They reported in radiologically. The engagement, contrary to what we believe, it was actually first time reported by Palmer and Widden in 1948, followed by Burkhardt and DBR, and that's where in 2000 onwards, the entire philosophy of the recurrent dislocation started changing, especially those mild to moderate type of Hill-Sachs lesion, which eventually became somewhere something like off track and on track. So no more we are actually into mild Hill-Sachs lesion, small Hill-Sachs lesion, moderate Hill-Sachs lesion. It's all about now whether it is on the track or is it off the track. There are various ways by which you can actually evaluate. So there are just the X-rays, then you can have some indices, you can do the CT scan, MRI, and lastly, as Samir and others were trying to emphasize, that what is the role of actually arthroscopy. So size of the lesion can, the first time it was described by the Rowe et al., it was based upon the axillary radiograph, where he said it the mild to moderate to severe, where according to these parameters, said that again, it was not very categorical that how do we make the decision, like whether this mild to moderate size of Hill-Sachs lesion, is it important to address or not? Severe, probably everyone knew that yes, you have to address, but no one knew what to do for mild to moderate. So I'll not discuss much. That's why these particular things, rows and so many other indices later on, they have kind of disappeared. No one wants to discuss anymore. Bigliani gave another set of indices, wherein in 1996, where they said less than 20% is a minor defect, 20 to 45 is moderate, and 45 more than 45 is a severe defect. Many views, right from the Steichen notch view to some other views, very important. Probably 15 years back, everyone wanted to do that. We all know what is it. It has got one of the highest diagnostic value, especially the Steichen notch view among all the radiographic methods. But prognostically, no one can say how important is this Hill-Sachs is and how big Hill-Sachs lesion actually I can ignore. So all these special views, they have got a good diagnostic value, but not really any great prognostic. Another view is a Garth view, which is an apical oblique view. It is again having a good diagnostic value, but not much prognostic. The Pascal Bolo in his eye size index, he said if you can see the Hill-Sachs lesion in the APU view of the shoulder with arm in external rotation, it gives you probably 0.2. But later in 2010, Krause et al., they said that this particular, the index Hill-Sachs lesion has got a low to poor inter and intra-observed variation, slight change in the rotation here and there, and you may not be able to pick up this lesion, and not everybody will pick up. Then the same person, Krause, came up with the AP view in internal rotation. This also picks up the lesion very nicely, and they actually came up with this index of the depth versus the ratio, the radius of curvature of the head. Having said that, they didn't go in detail about this particular index, that is the D to R or P to R ratio. Philip Hardy in 2012 came up with this concept that they divided this into various categories, less than 10%, 10 to 15, 50, or more than 20%. And they realized when they did their study retrospective, they realized that the patients who had the ratio less than 16.2, they had good to excellent outcome after the scopic stabilization, but fair to poor after if the ratio was more than 21%. But again, in the prospective, no one knew what to do about these lesions. Should you be stabilizing the lesion, which is 15% or 14%? No one knew, because again, the off-track and on-track concept was not really into the force, though it has already come in 2008, but it was not really into force. Similarly, other studies also kept on coming. Another index, that is the Hill-Sachs quotient or Kralinger's quotient. He did a study on primary dislocators, wherein they actually followed up only 166 patients for 43 months on a mean, and they saw the three indices. X is the width of the lesion, Y is the depth of the lesion, and Z is the superior inferior width of the lesion in the Bernoulli's view. And they multiplied these three, and they came up with this grading that if it's less than 1.5 centimeters square, I don't know, I have read the original paper, I don't know, when you multiply the three, it should be cube. But anyway, they said it's a square. Less than 1.5 is grade 1, grade 2, and grade 3. And what they found, if the multiplication of these three dimensions is more than 2.5, that is a grade 3 lesion, the recurrence rates were quite high as compared to grade 1 and 2. Between grade 1 and 2, there was no difference. So in summary, if I have to say, there are many radiographic methods, there are many indices which have come up in last 15 to 20 years. I have skipped at least 4 or 5, but because I didn't find any reason to discuss it, because it's going to take time. They have very good diagnostic value. You can figure out that yes, there is a Hill-Sachs lesion. Overall, just fair to good inter and intra observation. However, one of the study that the Bushnell, they said in 60% cases, actually you can miss it. Problem is, you do all these, fancy X-rays, but you can't make a decision. Then why worry about these X-ray? And hence, most of the people have stuck to one simple AP X-ray in the assessment of Hill-Sachs, or maybe just no one wants to actually assess the Hill-Sachs lesion X-ray. Coming to the workhorse at the moment, that is the CT scan. The assessment of the Hill-Sachs can be done by the CT scan axial cuts as well as the three-dimensional pictures also. So you can measure the head of the radius of the humeral head, defect weight, defect depth, length, lateralization angle, and so many things, which again, as being an orthopedic surgeon, I'm not really bothered at the moment. I just want my radiologist to give me the measurement test, tell me, is it a significant Hill-Sachs lesion or is it not, as Nilesh was very categorically pointed, because I have no time to sit and do all these indices. Said that, again, you can measure the depth to the radius index. If it is more than 15%, the surgical failure rate can almost inch up to 56%. And if depth to this head radius ratio is less than 15%, probably the recurrence rates are less. Again, it basically, if you carefully see, they all are talking about how wide is it. How wide and how deep is these lesions. That's how they start becoming more and more engaging. So many more studies have come up. I'll just skip off most of them. Don't want to. This one is study which came up in 2018. This is one important study. They said that most of the parameters, if you take up in the CT scan, whether it is the depth, whether it is the weight, or it is the length, there is an intra-observation. However, the error percentage is more when the lesion is shallow. And the smaller lesions can have a very high error as compared to larger. Now look at this one clinical picture. This was one case where Sami's philosophy comes in picture. So yes, largely we can believe what the what radiologist has reported, because that would fit into the, the 99% of the curve of reporting. But there are some cases wherein you will see this kind of Hill-Sachs lesion. Ramakant sir, you know whom I'm talking about. So this one sometimes, this looks okay because radiologist reported only till here, but when we went inside, we found that it was a huge Hill-Sachs lesion. It was actually off track, which was reported as on track lesion. Also, the 3D CT is more reliable than 2D. So, you look at this, when they measure the lesion, they measure only till here. Whereas you have got a lesion which is extending far more medial and you don't know what to do for this. Should you just ignore this, or you actually do the remplissage at least for this part, because you can't keep on curating this huge part of the cartilage. This is a lesion which did engage. But looking at all this, I decided not to do this because in between the cartilage lesion was too big. Many more studies like that I'll skip off. Then came the landmark study of Giacomo along with the Itoi, where CT with a 3D, and he discussed a lot about off and on track, which I'll show you in another 1 or 2 slides. Said that the Snyder, they said that there is a problem of inter and inter-observer reliability on and off track method. According to his study, there is about poor inter-observer agreement. And the biggest problem sometimes can be difficulty in defining the medial margin of lesion. Now look at this lesion. This is actually the part of the infraspinatus. This is where our radiologist defined the lesion can actually extend up to here. So sometimes when you have a very shallow medial lesion, it could be one of the, Yorkers in your clinical practice. And that's where you have to take the, as Aditya was trying to say, that there's nothing, one thing which fits into the picture. You have to, at the end, you have to take a decision on table. Should I leave this, or should I at least do the remplissage for this part and ignore this little bit of cartilage here? The recent study by, it's published in American Journal of Radiology, which says that off and on track on MRI can be compared very nicely with intraop arthroscopy. And that's what probably, again, Aditya was saying, that if you do the measurement very well on the MRI, not necessarily you always need a CT, but yes, your acquisition should be in a perfect plane and the quality of MRI should be good. Then came the health. This is where the entire, I think, the concept of management of Hill-Sachs lesion changed. Till then, everyone was telling, yeah, it is large, it is big, it is small, it is this, that, but no one was telling to manage or to leave it. So Yamamoto, when he published first time a study in 2007, they came up with this glenoid tract. I'm sure that all of us know about this glenoid tract concept. I'm not going through the detail of this. So this tract is located medial to the footprint of cuff and is 84%, 83 to 84% of actual width of glenoid rim. As long as both are, the glenoid tract, the width is remaining onto this tract, it's an on-track lesion. If it is out, the same thing remains, goes out. So this is where the glenoid and the Hill-Sachs actually merge. And this is what precisely we wanted probably, a couple of decades, that how do we say that these two are correlating with each other rather than looking at these two as a separate concepts. So again, if you look at this patient here, this one again, I got stubbed. My Hill-Sachs index was smaller, but when I put an arthroscope inside, anteriorly it was not looking big. Look at this little superficial lesion, not a very deep lesion. You have a Hill-Sachs lesion, but then you have got a cartilage and then again a small superficial lesion. And these lesions sometimes are missed on the CT scan. So in summary, I would say the plain radiography has role for screening, but overall a low inter-observer reliability and have less accuracy for pre-op planning. CT scan axial images are excellent for width and depth. 3D CT does slightly better than the 2D, and you also get all the acquisitions for the glenoid. And bigger lesions generally tend to engage. But now, since the concept of off-track and on-track has come, we can always utilize those particular concepts. 3D is at the moment considered to be gold standard for HSL evaluation. I would like to take later the Aditya's inputs. And newer studies suggest that 3D MRI is coming up as good as 3D CT. So maybe in another 5 years, when we'll have better machines, better technology, the 3D CT might gradually be, going off, because here there is no radiation. At the moment, the role has to be further investigated. Thank you so much.
Thank you, Vivek, for wonderful talk on Hill-Sachs lesion. So do you have any question from Dr. Vivek?
Vivek?
Yeah, Nagaraj.
Yeah, Nilesh.
Yeah, Nilesh, sorry.
Yeah. Vivek, so effectively from a surgeon's perspective, we know that for us, there are three factors to be considered. A narrow versus a broad, a shallow versus a deep, and a superior versus inferior, right? So these are the three things when I would be looking at the scans. These are the three things which are going on in my mind to look for engagement, right? What are your thoughts on this? That I know that you've written extensively on remplissage. You're a firm believer of remplissage, but what is your first take home when you look at a Hill Sacs and with these 3 points, right? How would you approach them, or is there any way to quantify them? Let's put it that way.
Actually, Nilesh, for me, I'm yet to come across too much about the superior and inferior part, because most of the time they'll be, going quite inferior, and I have never made a very, voluntary approach to measure superior and inferior part. Most of the time we try to measure actually, the mediolateral width. And I forgot to tell you that actually we have just finished the study where we correlated the 3D CT, this on track versus arthroscopic correlation with a specially designed scale. And our thing is almost ready. Because of my patent reason, I could not show it. So maybe next time I will show exactly how are we doing that part. So I firmly believe that mediolateral part is more important, because that's where the tracking concept comes. The depth, again, most of the lesion actually you see, unless and until they have been very violent, like epilepsy, or maybe the kabaddi where somebody has literally jumped and it has really gone into most of the lesions are not really very deep. I mean, when you look at them arthroscopic, they are pretty wide, but I'm yet to come across something which is, half a centimeter or 2 centimeter deep. So for me, the most important part, number one, is the mediolateral width. Number two is actually, if you read the Nagakawa's paper, where they emphasize that any time if there is a Hill Sacs lesion, it becomes a bipolar lesion. And a approach, in my personal experience, whichever my recurrent dislocation where I operated with only Bankart and where the lesion was not really off track, even though they are on track, they somehow there were a lot of recurrences. Not, I would say a lot of, but many who recurred were the cases where I did not do the remplissage. So over the years, I have got a little bias toward the remplissage. And my study, when we did in long term, we realized that the loss of range of movement for a non-overhead athlete is so insignificant that it just doesn't bother him. It just doesn't bother him. Yes, I have got a javelin thrower. Maybe I'll start changing my plan. And that's what probably Dr. Ramakant was trying to say. But how many times we get those patients in our routine practice? So I would today at this in 2021, if I have to err, I'll err on remplissage and be safe rather than not do it. But take it as my personal opinion, not completely based upon the, what is being practiced everywhere.
No, Vivek, I think I completely agree on that point, that whether the remplissage really hinders the extra rotation and all. And if we follow the recent article, even by the master like Pascal, he told that the extra rotation loss, even in the players, it's like around 8 to 9 degree, which is quite less. Even it is non-athlete people, 8 to 9 degree of abduction, extra rotation, and 90-degree loss is probably he is not going to perceive even. So I think whenever we are in doubt, and if the Hill Sacs is parallel to what the Barker's concept, if it is not oblique, if it is parallel, and the most important part that you told, it is the mediolateral, let's say, not the depth. If it is parallel and if it is in the glenoid off track, mediolateral length, so there is no harm in adding the remplissage. I completely agree on that.
Vivek, you spoke about Hill Sacs interval. How do you define your Hill Sacs interval? Because that is very important as far as the consideration of the glenoid tract as well as the articulation of glenoid tract on the humeral head. So any
that is
method where
yeah, Roshan, so that is actually from the from where the infraspinatus attachment is to the medial most the margin of your Hill Sacs lesion.
Do you do arthroscopy?
I think Roshan,
no, that is measured by them also. But for almost 100 plus cases for my study reason, I kept on doing it arthroscopically also by having a specially designed instrument. Because the whole problem in arthroscopies, you put your scale, the so-called graduated probe, it's extremely difficult to measure. So we designed an instrument which can give me real-time idea. that what is my glenoid width and does it match or not. But as Nilesh and everybody said, see, the practical difficulty, especially those who do the instability in the lateral position, is suddenly if you want to do the letage, it's a Herculean job. You got to shift him into the B chair position. So those who do the probably instability in the B chair, for them it is easy. Okay, I got a doubt. I will straight away go ahead and do the letage. But for me, I need to have a almost clear the pre-op idea. But the Roshan sir, it can be measured arthroscopically also. And it's almost same.
Yes, I agree. I agree with
Roshan.
Because in all cases we also do arthroscopic assessment.
Yes, you can do it, and it's a good thing. You start getting an idea that how close, and sometimes when you have a completely, out of the, the blue finding, you can always communicate back. As Aditya was telling, you have to tell your radiologist that this is one funny finding I got. Otherwise, they will never look back. They feel okay, all is well. But they need to be told that I got this, then they go back and see the image and they'll, oh, this is what. So in superficial lesion, very rarely the superficial lesions, sometimes the Hill-Sachs interval can be a problem. Aditya, what do you say?
Yeah, no, that's exactly what I was going to talk about. It's a great talk, but yeah, exactly that is that I can tell you that 99+% of the cases where I have come back with something discrepant between arthroscopy or surgical findings and radiological findings, we've just gone back and looked at it together. And in 99% of the cases, we found it. And not only that, it's become part of where we miss less and less, because now we know that's where we find it. So,
absolutely,
which is sort of the case that I showed you earlier when I was talking about measuring the Hill-Sachs lesion. You just got to look at the superior most sections. You got to look at it and you'll find it and you'll blow by it, or you will, miscall something. So I think rather than actually we invest a lot of time in saying we should find a new method of doing this, we should find a new method of doing that, and we should look at 3D MR and 3D CT, the answer is there. It's just we haven't gone back to look for it concertedly. And if we do that more often, I don't think we're going to look at other things. So I strongly recommend that you communicate and send back bad feedback and make people look back and get those answers, because they're there.
Aditya, just one simple question. Aditya, just 1 second. Aditya, just one simple question. Whether there is any significance of the Hill-Sachs interval at present, because we talk of the medial lateral extent of the Hill-Sachs. Why we talk of so much on the Hill-Sachs interval? Your take on that?
For me, it's just a question of when you look at the total length between the medial most margin of the Hill-Sachs and the base of the the medial most part of the infraspinatus footprint. I think those things together are what determine what is the area that's going to engage. But what's more important actually is that medial most extent of the Hill-Sachs, because that's the first part of the Hill-Sachs that engages with the posterior aspect of the glenoid.
Yeah.
So that is the key thing. And then you got to fill up all the space behind that, because if you don't fill up all of that space, then that sort of defeats the purpose.
So basically we don't have to focus on the Hill-Sachs interval. It is the medial lateral extent again.
Yeah, from the medial most margin of the Hill-Sachs lesion to the infraspinatus footprint.
Yeah.
So Aditya, can I summarize like this? Like today, at the moment in 2021, per se, there is no role of X-ray. We should not be wasting our time on X-rays and assessing all those things and straight away move on to the CTs.
Yes, but the only reason I do say X-rays is because
X-rays has to be done as a part of.
But using X-rays to plan stuff, I think is just being a little bit. I mean, it's like saying that we should still take a bullock cart when we go to work because we have it, that kind of thing.
Correct.
Vivek, I have a question.
Yes, sir.
We have been talking about remplissage in primary Bancards, and you seem to be a strong proponent of doing remplissage or on doing remplissage in primary Bancards as well, where the lesion is not off track. So when you analyze your cases,
sir, I will just interrupt you for a second, and I'll bring back to one concept which Roshan told right in the beginning.
Yeah.
If you carefully look into this whole on track and off track, and including the Dr. Iji's famous experiment, all these things are in laboratory without any dynamic force.
Correct.
Now let us say Aditya measures, or my radiologist measures, and he says the Hill-Sachs interval is, let's say 19 mm, and glenoid tract is 21. Now you have got 2 mm of difference. So this 2 mm makes it on track. Okay. Yeah. But who knows, this on track will be extremely going to just near engagement in the dynamic force. Like somebody going to throw Okay. So this dynamic factor, this is what Roshan was trying to say, that dynamicity, a lot of other factors have not been taken into this concept of, the so-called hill sacs. And that's where the Nagakawa's theory comes in the picture, where they say that every hill sacs is actually is like a bipolar lesion, and beyond the smaller ones, after that you start thinking how to manage. So with that philosophy, I don't believe too much into this, because 1 mm here and there.
No.
No.
My question is not that. Your philosophy is very well taken, and almost all the studies are being done in lab. So right from the tensile strengths of the graphs, there is many questions which can be raised. I completely agree to it. In clinical scenario, when you said that you have done a study where you found that if you would have done remplissage, the recurrence rate would have been low. That's what you said, correct? Now, my question is, did you really analyze other factors for the recurrence? Whether it was a technical error, what was the main cause of recurrence in all those patients where you found that probably remplissage would have worked? I mean, in retrospect, you must have thought over it, isn't it? Because it looks like the answer is to prevent a failed Bankards, which is just hardly 4%, you add remplissage to everyone. So I think we need to question this concept, and that's why I'm asking you whether there were any technical errors, whether it was ligamentous laxity, there was these patients were hyperlax, the number of anchors put were less. So you'll have to exclude all those other causes before you say this. That's why I'm asking you this question.
I agree with you. We did analyze, but though the number of failures were not so many that it can give me a concrete, the tilt. So coming to the technical aspects, okay, I can say that I've been doing a fairly good numbers and reasonably well-established technique, and I did not took my first 3 years of my practice. So I knew that I maybe at that time I was learning. So everything was, I think, 2012 onwards. Number one. Number two, we never used anything less than 3 anchor. So if you read the paper which we published in JSCS, there were always 3 or more. Sometimes we have used 4 also. In fact, my lower anchor is always double loaded. So I take, in fact, the lowest bite from the inferior capsule also.
IGHL. Posterior part of the IGHL.
Yeah.
No. So you did not find any. So you did not find any technical errors or any other causes of recurrence.
I agree to that. That's what, sir. I did not find any major technical error. See, one patient may have ligament laxity. Now, this ligament laxity itself is, Milind sir, it's such a difficult thing to define. Who is 4, who is 6? It's a borderline thing. But yes, largely we had ruled out embries, largely any major capsular injuries, largely have I not, the bone losses were also, the 2 groups had comparable. So not that who had recurred had something like, let's say 22% bone loss. Okay, not that they were all same group, they were falling. So, and in fact, after that, couple of more studies have come up which said that yes, remplissage reduces the incidence. Only thing is that maybe in 10 years
that is all fine. My only contention of saying this is that we need to analyze the primary cause of failure before we really make a statement that a remplissage. Yeah. So I think we can have a study on this. Whatever revisions we are doing, we should be in a position to document the cause of failure.
I agree. In fact, all of us should start pooling. Some days we should just discuss our failures. Why did it fail?
Right.
And then we'll start coming to know, why did it fail actually?
Exactly.
Was it only the technical error? There was some things which were not in my hand.
Rajkumar, you raised the hand.
No, probably in Vivek's case, I would like to know who assessed the results. Is it the principal surgeon who always assesses the result, or there is a neutral person who is assessing your results?
Which part of the result you are talking about, sir?
Your outcomes.
No, there are, dislocation, whether I assess, Rajkumar sir assess or Nagaraj assess, it's remained the same. My shoulder dislocated, which I considered as a failure. Okay. Range of motion was assessed by a different person, not me. So other scores will not matter, and we took it as dislocated or not dislocated. Okay. In fact, my paper has recently come up in a review where they said that I have not defined, some things. So I just took it as, did it dislocate or not? So not the feeling of apprehension, not the feeling of would it dislocate. So maybe we did not go critically into that, but dislocate or not, I think that will not change with anybody.
Now, question is for all the 3 speakers who have spoken so far. Should we rely only on the imaging, or should we combine the clinical findings, the imaging, as well as the intra-op, as Samir put, to really plan the way you manage these kind of patients?
I'll go first and say you should not go only on the imaging, 150%, because
Absolutely.
there are so many more things. The imaging is just a part of the puzzle, and you can't account for demand, soft tissue laxity, people's ability to adopt, and all that stuff. On imaging, we are only going to give you some basic morphologic features that help to guide your decision making. There is much more to this than just imaging. So, which is again why I say the moment we start henpecking and nitpicking over 1 and 2 millimeters and 2 and 3%, we are losing the game completely. We need to work with large concepts and say this is what imaging will provide us. There will be variability to these things, but we need to put it in perspective of the individual patient. And we always stand by the rule: don't treat the image, treat the person. So I'm definitely going to put that out there.
We have a next talk by Dr. Karthik, who is going to talk about the scientific consensus. What exactly is today's scientific consensus on instability and assessment of bone loss? Karthik, are you ready with your talk, Karthik?
Yes, sir.
Yeah, please go ahead, Karthik. Can you share? Yeah.
All right, I think much of this has already been discussed, so my job is quite easy, and I'm just going to sum up all the 3 talks and all the discussions quickly and give you some take-home points. So we now understand that we need to look at bone loss both at the glenoid and the humeral side. Now, the whole history was very nicely summarized by Nilesh, like why we started looking at bone loss, because we actually started doing arthroscopic Bankart on all comers, and we found that there was a high rate of failure. And some real good thinkers looked at their cases of failures in over 2,000 cases, and they found that the glenoid side bone loss was a real culprit. So once we started realizing that the glenoid side bone loss was a problem, then we went back and looked at the humeral side bone loss as well. And now our understanding has evolved to such an extent that we do understand to some extent the interaction between the bone loss on the humeral side and the glenoid side. Now, is there a goal? I've just looked at literature to find out if there is any gold standard in assessing glenoid bone loss. And as everyone talked about, there are people still use radiographs. There are people in Europe who use radiographs, Bernard-Jouyou, as their standard way of assessing bone loss, but no one can contest this sort of a picture you get from a 3D CT scan. So when you see this, you can your choice is already made. As a surgeon, you want to actually know what will work for the patient. And if you're given a picture like this, then your surgical decision is made. So there are several ways, 2 main things. So again, it's a summary. It's going to be a repetition. So 2 different ways of doing it. One is the surface area assessment for the glenoid bone loss. Other is the width assessment. So this is the Griffith index. This is the first index which came. So you draw a line right from the base of the coracoid, a perpendicular line along the center of the coracoid, and then a line perpendicular that at the maximum width, and then you measure the lost width. That is the Griffith index, and this is the best fit circle. Again, we know Aditya talked about using the circle, fitting the circle onto the posterior inferior surface. You can do that, or you can actually draw the circle on the normal side and take the same circle and superimpose it. If you have a CT scan in your institute, and if you get to play in the console, you can do that, and you can see what's happening there. And this is the surface area method. So this is the width method. These are the 2 different things. Just keep this in mind that there are 2 different ways of assessing glenoid bone loss. One is the surface area method, where you need a formula, where you need a software. You can't do it on every computer, every CT machine. So that's a little tricky. So it's when it comes to Covishield and Covaxin, it is not your preference. It's basically what is available in your nearby hospital. So in my hospital, I don't have a software. So you really can't measure the surface area. Although we know that surface measurement is better because it is independent of the orientation, the tilt of the glenoid. So all you can do most easily is this, the width measurement. That's what Aditya says he does. And that's what most of us do. And if you do this right, it is accurate to the most extent. All you need to know is how much bone is lost, because that is only one factor in your decision making. This is the standard technique by Gerber. This, I think, a lot of people still use this. He actually draws a line along the anterior border of the glenoid, and then there is a ratio comparing the diameter with the anterior line along the anterior cortex, and the normal ratio is 0.7, and anything less than that, anything more than that, then it's a bone loss. And this is the ImageJ software. Now a lot of us have access to the ImageJ software, and you can actually draw a line and measure the whole surface area of the normal glenoid and compare it with the this is the D Filipino method. So this is again another method. Now this is Chunjian's paper comparing the surface area method versus the width method. So he says the surface area method is more reliable, inter-observer variability is better, because there is a little bit of a confusion as to where to place that line. Dr. Rajkumar was pointing to that, saying that you can overestimate with the width method, you can actually overestimate the bone loss. It is documented. So coming to the gold standard, is there a gold standard? This is fresh off the press. 17 different methods of assessing bone loss, area measurement versus width measurement. As Aditya mentioned, every surgeon has a method named after him. And there are 6 different imaging modalities used among all these papers. There's no gold standard, but see, the most important thing is the idea and the fact that you're looking at it, looking at bone loss itself is a very good thing. So once you start looking at it, and you will pick up significant bone loss, you will not miss it. The insignificant, as he says, between 1 and 2%, you're not going to make a major, your decision is not going to majorly change. So 3D CT at the moment is probably the best. Again, we are reiterating it. Volume measurement might be better, as it will take into account everything: version, concavity, location of the defect. You don't need to worry about all this if you're measuring the volume. But for that, you need a formula, you need a software. You can't do it on the normal CT machine. But then if you use ImageJ, you can actually copy the picture and put it on your computer, open it and use the ImageJ software. It is reasonable. But then again, as you say, all methods are actually reasonable. The best fit circle method along with the glenoid index method seem to be reasonably accurate. Now this is the surface area loss measurements. PICO method, use the contralateral shoulder. And again, with the one thing I found in literature is that there is conflicting evidence whether width loss measurement can be used on MRI. For a surface area method, they seem to suggest that MRI is equal or not too bad. The only thing is, in minor bone loss cases, MRI can be just used. Now you see a patient who's just once or twice dislocated. You can see that on the MR you see a very normal glenoid, and the patient is not overtly apprehensive. There is no mid-range apprehension. Clinically, you're not worried about bone loss. Then you can just do away with an MRI. But obviously, if you're worried about moderate or severe bone loss, then 3D CT is the best. Again, this is another. This is a new sort of review, which is called the scoping review. This is the new thing. Scoping review is not as difficult as a systematic review to do. So anybody wishing to do a review can do a scoping review. This also finds some printing space nowadays in the publishing industry. So here again, this again takes into account all the 50 papers looking at bone loss. And again, the measurement in Hill-Sac, the measurement of Hill-Sac bone loss is not as well documented as glenoid. So glenoids, a lot of studies on glenoid, but Hill-Sac not that much. Again, the role of orientation, as pointed out by someone, horizontal and more medial, all that needs to be taken into account. So again, as is all shown by Vivek. Now, the most important thing is the interaction between the glenoid and the humeral bone loss. So that is what has really triggered our imagination, and now we got the glenoid tract. Now every radiologist talks about glenoid tract, which is a very good thing. We have educated our radiologists to look at glenoid tracking, and they are giving us various measurements. Now this recent paper by Giacomo, I'm sure most of us have read this paper. So he has taken the ISIS and he has used the glenoid tract instead of the plain radiographs. He has instead of that, he has used the 3D CT and has come out with a score. And this score seems to actually reduce the number of cases on which we do Latarjet. He says almost 70% of patients qualify for a arthroscopic bank heart, versus if you use the ICIS score, it is more than 60% who are getting a Latarjet. So this is the score which we use, and I've been talking about this for a while now. And in our score, actually, our algorithm actually needs a 3D CT scan, so all the patients get a 3D CT anyway. And for if I think most of us know what tracking is, but for the benefit of the youngsters, I just want to quickly touch upon what the glenoid track is. Now, basically, when you abduct and externally rotate the shoulder, the area of the humeral head which comes into contact with the glenoid is called the glenoid tract. So the glenoid tract is the tract formed by the glenoid on the humeral head. So now it is 84% of the humeral head, because the 17% goes along the insertion of the cuff. So that's so we talked about Hill Sac interval and glenoid index and how the off track and the on track lesion work. Now the medial placement of the Hill Sac lesion actually causes engagement. That's because of the position, and even if it is not very wide, if it is medially placed, obviously it is going to get engaged. Now this is the arthroscopic measurement. Again, Vivek going to come out with his own method and teach us again. So this whole concept of tracking has been proved in vivo. They did a 3-dimensional motion analysis using open MRI, and they found this concept is true. This whole thing was theoretical, and now it has been proved on humans in open MRI. Again, it is not a dynamic fluoroscopic image, it's only static series of static images. Now, can you, so we know 3D CT is the best, but can you use CT scan, the MRI? Now that's the problem when it comes to measuring the Hill Sac index on the MR. Now the radiologists have difficulty in actually identifying the infraspinatus insertion. Infraspinatus insertion is oblique. It is not very clearly defined like the supra insertion. So there is a lot of inaccuracy in measuring Hill Sacs in the MRI. So as far as Hill Sac goes, I think CT scan at the moment in literature seems to be the best. So I would just quickly conclude saying the consensus is that if you suspect bone loss, there is multiple episodes of dislocation on the X-ray, there is loss of anterior cortex, you always evaluate for bone loss. When you evaluate for bone loss, I think if you're looking at a moderate size bone loss, definitely don't shun away from getting a 3D CT. Measuring Hill Sac, there is even on the 3D CT, there is a lot of inconsistency. It has to be very well defined. Even the most senior authors have said that we have to actually define the measurement better so that we can compare two groups, compare two studies. Now, the track actually has given us a very good tool for us to actually understand how the bone loss on either side actually interact, and that has actually given us a good way to make decisions. But again, as reiterated by everyone, now earlier, as everyone was saying that arthroscopy is not the only tool to manage shoulder instability. Likewise, bone loss is not the only determinant of success. It is a very important determinant of success, but it's not the only one. So look at other factors also. Assessment of glenoid tract after Latarjet. Somebody was asking this question. Do you actually, and there is a study, this study actually, they measured the coracoid dimensions and the glenoid dimensions, and they found that if the glenoid bone loss was too much, that even after the Latarjet, if you have an off-track lesion, then the chance of failure was very, very high. And there are people who are doing remplissage with Latarjet in severe bipolar bone loss. You can actually do that. But the only thing is you place the anchors, you don't tie the anchors, because if you tie the anchors, putting your Fakuda can become difficult. So you place the anchors, then come out, do your Latarjet, and then tie the anchors for your remplissage later. So in this case, you will have to make the patient sit and then do your remplissage in the B chair position, which is not very difficult. Actually, you can do it. And this is also being studied. Again, these are all things which we need to keep in mind, because all this treatment is individualized. Recently, I had to do a patient where I did a remplissage with Latarjet in that patient because he was young, he had severe bone loss, and he was hyperlax. All his joints were lax. His Brighton was 9/9. And I was not sure that even after building up the glenoid in the front, he might still be loose because his capsule was so voluminous. So I actually did a remplissage with Latarjet, and surprisingly, in 8 weeks' time, he got back all his movement. He was very happy, but I was worried. So even that actually, all this restraint, constraint, the shoulder can still become a little loose. So algorithm which we follow, and less than 0.8 we do Latarjet, but then the rest of the cases the algorithm. That's my consensus there. Thank you very much.
Thank you, Karthik, for your lucid presentation. Roshan, if you have any questions for Karthik, or Vivek, if you have anything to discuss on the forum. Nilesh.
We are open for discussion now. If anybody has any question.
Karthik, as you said, Latarjet plus remplissage. Do you think it's a overkill?
Yes, this is so. That's what I'm saying. This patient was a 19-year-old boy who was very hyperlax, and he had significant glenoid bone loss. Now we all know Latarjet fails in hyperlax patients. If you do only Latarjet in a patient who is hyperlax, it is a contraindication. Actually, according to Jill Walsh. Jill Walsh recently has published a paper on contraindications and complications of Latarjet, and in that, hyperlaxity is one of the contraindications, because the hyperlaxity is not addressed in Latarjet because we excise the capsule.
Okay. So, yes, Gaurav, you have a question?
This is for pretty much everyone, and more for Dr. Vivek Pandey and as well as others. You see, we, as you showed in one of your videos, said we do see those hill sacs where, there is this hill sac, a strip of cartilage, a narrow strip of cartilage, and then some more of lesion, which has engaged at some point, isn't it? So in those, should we completely ignore that strip of cartilage, curate it out, make it a big hill sac, and then fill it up with remplissage? And in that case, would your number of anchors change? And how would you determine whether you're going to put one anchor for your remplissage or two? I think Dr. Nilesh was also saying something about top to bottom, as in superior to inferior length of the the hill sac. Will that also affect the number of anchors that you put in?
Gaurav, you're right. So those situations are not very common. Maybe you can say maybe 1 of the 100 or 2 of the 100 where we see those things. So if that lesion, because you saw those 2 videos, one was quite medial, so I had no courage to curate till almost a centimeter of cartilage, and the other side, the glenoid looks, the labrum was not bad. He had actually had that during kabaddi. Okay, the bone loss was not much, so I just did the remplissage only for the part which was medial to that, and I left that strip, and I did repair anteriorly. So those situations are not very common. Yes, if the lesion is wide enough and superior to inferior long enough, sometimes I do add the second anchor, but I would still confess that my workhorse most of the time I put only single anchor. Somewhere in the center, I have not regretted. I am still not very, that I don't want to put 2 anchors at the back. So I don't, and I think Dr. Ramakant knows, there was one fish. We have jointly managed here and there. So, that was one boy who had that, and then I left that. I left that because I thought, okay, that this lesion is too medial. I don't want to cure it. And then he had an epileptic fit, and then he redislocated that shoulder, which was further managed by Raman sir in Delhi.
I think the data is quite clear on this. Although presently we are finding good results with remplissage, if you are over tensioning by going very medial or curating too much, there is a risk of creating in the long term muscle tendon tears, muscle fatty infiltration in the infraspinatus. We still don't know long term of our own patients.
Exactly.
Follow-ups, we don't
actually.
That's what Nagraj, I gave a closing statement that we don't know 10 years down the line, we'll know whether did we do any major harm.
Correct.
Fine, it is preventing the dislocations at the moment. Because I remember in last SESI meeting, I think who was he? He was showing that in some cases they have got, little small tear, intrasubstance tear of infraspinatus. So Butch Krishnan, he was showing that they are doing some MRI study. So let's say in 5 years, 10 years down the line.
And one more thing which I feel all of us would agree, anytime we do something non-anatomical in the body, sooner or later the body is going to reject it. And discharge is non-anatomical. We are filling something into somewhere where it is not supposed to be.
See, it's both ways. You're either doing non-anatomical anteriorly or you're doing non-anatomical posteriorly. Latarge is nothing anatomical.
So that's my point. What do we say, Nagaraj, about Latarge in this instance? That body is going to reject it. Because I got one of my patients who I did a Latarge 11 years ago. And a nicely executed Latarge. The inferior screw was not, the direction was not good, but graft position was excellent. And he lands up with a severe osteoarthritis at 32.
Therefore,
he had tears in his eyes.
I believe Latarge is a salvage procedure. It is not a...
Yeah, so suddenly somebody thinking that because this is the bone loss, and I should probably 15%, I should probably tip towards Latarge for especially somebody who's on the initial phase of the learning curve, and then everything is screwed up. Once you go a bad Latarge, everything is gone.
I agree.
So I think that's what Dr. Milind was trying also to say, that a very good technique, the whatsoever is being said about the Bankart, an excellently done Bankart is quite good. And all of us have seen, we have been operating for close to 10 years. I mean, most of us here. And we have seen that the recurrence rate in our population, let's not compare ourselves with the, the Western population, the recurrence rates are far less.
Yes.
No, because they are not mad people who want to do the mountain, biking and hiking. I mean, the ordinary people, they do well.
I think the today's talk was only on assessment.
Yes.
So we have certain cases to be presented by the presenters. So I'll request Dr. Sujit Jose. Sujit, you have one or two cases. So quickly, only up to the radiological assessment, the bone loss assessment. Then we have one case from Mukesh and one case from Samir, and then last is from Dr. Vinay Pandey. Yes, Sujit.
Hello, good evening. Thank you, Dr. Roshan. So we've gone through very excellent talks.
And this is an open discussion. Anybody can come up anytime. Okay. So we are open for all now.
All right. So I'll go through a case. A 26-year-old male patient. He had a recurrent dislocation of the right shoulder. There were more than 20 episodes, and he was quite unstable, and his activities of daily living were affected. He wanted to do overhead sports. He used to play badminton, and he was a bowler as well. Everyone plays cricket in India. So he was not able to do both with his shoulder, and which he wanted to return to. Those are the clinical tests for instability. His Baton score was less. There was no laxity. The opposite shoulder was okay. And that's the Job's relocation. Patient by the side of the table. And he was apprehensive at 1995. And those are the radiographs. As Dr. Vivek rightly said, the radiographs have much lesser value. I use them mainly for the follow-up. So for follow-ups, I use the Bernagio or the true AP view, as you can see. The AP in internal rotation definitely is a good view to assess the Hill Sachs lesion there. But then again, it depends on the position of the Hill Sachs, whether it's superior or inferior. You can be misled by internal rotation view as well. I rely mostly on CT scans, especially when I expect a larger bone loss. So that is the right shoulder. You can see the inferior bone loss on the CT scan on axial cuts, and left on your right there's the left shoulder where you can see that the inferior the glenoid is good, and I'll go through the right shoulder again. There you can see the Hill Sachs lesion. When I rely more on the 3D CT, we have a good radiology team, and they do the measurements and the minusings well. And here in this case, we've done both the shoulders, separate CTs. I wanted to ask Dr. Aditya about this, we'll come after that, whether we should do with separate FOV or a single FOV, because in single FOV we get a more blurred image, which I feel can affect the percentage of measurement, but then want to do percentage of difference doesn't make a difference in your treatment plan. So that is the shoulders, and that's the sagittal cut, where best fit circle method. Again, it's technician dependent. The line of the cut can make a difference in the assessment, which you cannot probably reassess. Those are the glenoids, which are isolated, the humeral heads minus. You can see the anterior inferior bone loss. And that's the right glenoid and the left glenoid there. You can definitely see there is bone loss, but then it would be in the gray area whether we should go ahead with a bony procedure or a soft tissue procedure. We went ahead with the best fit circle method. That's a circle made in the inferior glenoid, and the vertical line there. There is more of anterior than anterior inferior, as Dr. Raman Khan said, which is more significant. That's the diameter. There is another question for Dr. Aditya, how to measure if you want to reassess, because in your packs you won't get the millimeters, you get only the pixels. So
no, that's not true. We get, so just both your questions to answer. One is in terms of whether you should do both FOVs. When we acquire the CT, it's not like an MR where we acquire one joint at a time. The image is acquired in its entirety. Subsequently, what happens is the technologist reconstructs each side separately. So scan-wise, you're not doing anything different. You just tell them, I want you to reconstruct both sides separately.
Okay, but what I understand from my radiologist is they use a coil for the shoulder, which is being...
For CT, not for CT.
Okay, only for...
Not for CT, only for MR. That's not an issue for CT at all. Yeah, so CT, that's not an issue at all.
Yes.
Yeah, so CT.
Yes, Aditya, that is the advantage, and that's the advantage of having the CT. You can have both in one go.
Yeah. I mean, whatever works for you. My goal is if I can get rid of the CT, nothing like it. If I have to do a CT, then I'll get one or both. Kya farak padta hai?
Usually is only one cut.
Yeah, because CT is that's the advantage. Yeah.
Aditya.
Yeah.
Sorry to come in suddenly in between.
No.
What is there a possibility that you can do just the one shoulder CT?
No, so when you go into the gantry, the radiation comes from all the way across.
All the way.
Across the entire body.
Actually, no, that's what this debate was happening. And I was telling, no, usually in the gantry, the radiation comes from all sides. No, you really can reduce the radiation by doing one side. I said, I'm not very sure. Okay, let me ask somebody.
You can't. Okay. Once you're radiating that whole area. That you're including both shoulders in that. What you can do is you can go back in and you can reconstruct each side separately. And when you do that, you actually do get better resolution than if you were to reconstruct both sides together.
Okay. That's a good point. Okay.
I understand that this can be done even afterwards, right?
Yes. So the thing is that sometimes you have a CT tech who may not know how to do it, but once the area is scanned, then you can shrink it down. You can do whatever you want after that. It's just that if you haven't covered the area, then you can't. Like you can't say that I scanned the chest, but I want more images of the abdomen. That you can't get.
Okay.
But
the millimeter and the pixel part.
Right. So the millimeter and the pixel part is so if you take when they give you the data that they're giving you, actually I can just share my screen and I can show you what you can do with this if you allow me to for a second. Because I do actually have a case with CT available here. So let me just share that quickly and show you. Here we go. Okay. So if you have, for example, a CT like this, right? Here you have your CT images. If you wanted to look at this actually my 3D crashes unfortunately on this machine, but you can essentially on the 3D image also, what happens is when they give you the 3D image, these guys give you these 3D images in a post-reconstructed format. And when you do the post-reconstructed format thing, then you get pixels. But if you just do it on the system in DICOM data, you can actually get the actual centimeter values.
Okay.
So that's possible. It's just a question of on which system you're doing it. If they give you post-processed images, then they're sending you essentially some JPEG images. So it doesn't have that perspective of what the size is. But if you're doing it, otherwise, then you can get that. That's not a problem at all.
And you don't have the access to their console where they do. So that's why you always get these pics.
Yeah.
So you see in some console sitting somewhere.
Yeah, they reconstruct it and they send you these images as screen captures in a sense, instead of sending them to you as actual DICOM data.
So is there any software you would suggest for measuring that on your laptop?
So we use HOROS. If you're a Mac user, then HOROS, HOROS. I think every orthopedic surgeon who uses a Mac has HOROS downloaded.
I use a Miley.
Sorry?
A Miley, M-I-E-L-E. That's what I use here.
On Mac or on PC?
On Mac.
I've not used that, but I'll check it out.
Mm-hmm.
And then if you want to use a paid version, then Osirix is always the one that is that people use.
Okay.
But yeah, this is pretty easily done. You can also tell your CT tech that you draw the images and you measure it for me, like give me the measurements on the image.
So coming back to the case, here I used Photoshop to superimpose a scale, which for the accuracy of the measurement, I made it for the talk alone. I don't do that regularly, but then that gives us the measurement of the normal, the affected glenoid. Yes, so that's the 83%, and the small d measured. And the percentage of bone loss measured here is 21.2. So that's again across 20%, where we would think about a bony procedure, or we can debate. That is a normal shoulder. The same best fit circle has been drawn. The same diameter, the 83%, where you can see that it is validated. Both the shoulders are compared, where you have a normal good side to compare with. Those are the CT scans of the humeral head, the dimension of the hill sacs. Again, I feel it is much more technician and radiologist dependent than the 3D CT, where you can assess it yourself. That's the hill sacs interval as I've measured here, which is 21.1 millimeters. Again, it's almost a tie between the glenoid tract and the hill sacs interval.
So sorry, I'm just going to interject with it. Can you go back to the measurements for the last two?
Mm-hmm.
And the one before that. There's something kind of, so the next one, for the hill sacs measurement.
Okay.
If you look at this slice that you're measuring the hill sacs on, you are actually at the mid glenoid level.
I know, I have not measured, sorry.
So that's what I'm saying. So this is where the mistakes happen. The reason I'm pointing is this is where the mistakes happen. You don't look at the sagittal, you don't look at the coronal to see where the hill sacs is. And you should get your axial section to that level to actually measure the hill sacs there. And that is part of the reason why, because there's this little bit of flattening of the back of the humeral that happens all the time. So you do have to be careful of that.
I put
is it, Aditya, is it somewhere near the coracoid, where the coracoid is?
No, it just varies because it all depends upon the way in which somebody is dislocating. So if you have somebody who's dislocating directly anteriorly, you'll see that hill sacs lesion is more sort of along the, like a little bit high, a little bit lower down. Whereas if somebody is dislocating anterior-inferior, you see the hill sacs is a little bit higher up. So it's very important to just sort of understand that. And even with the glenoid bone loss, when you talk about it as being anterior half, the vast majority you'll see oblique loss sort of along the anterior inferior quadrant and not this vertical loss. So I think there is an element to the directionality of dislocation that affects the geometry of both of these structures. And we need to take that in account, or at least understand a bit better as we continue to evolve in our understanding of dislocations and how we manage them.
If you're not tight on time, one more thing here is another paper by Moroder recently, a couple of years back, which said the curvature of the glenoid is important, because a smaller amount of bone loss is more important when the glenoid is more curved, which you have to compare with the opposite side to decide.
Look, I mean, anything is possible, right? I mean, and like we said, the key thing over here is that this is not the be all and end all of the entire management. It's going to depend on a few different things. So the question is, does the curvature make a 1-2% difference, or does the curvature hit you with a 5-10% difference? If the curvature hit you with a 5-10% difference, then I'm definitely listening. If the curvature hits me with a 1-2% difference, I'm saying, really, that's a lot more headache for not much more addition in terms of value.
I put these slides up to say the fallacies in measurement in a 2D CT, which I feel can go wrong. As you said, the point where you measure can be wrong, but then when you have an end face like that, your chances of going wrong is much less. So that's the report from our radiologist. We have a very good radiology team which measures it for us, and here we have almost a tie. So, would we go for a bony procedure? So that's a picture for the understanding of the younger surgeons. Picture I made for a review I've recently done. So that's an on-track lesion, even if the large hill sacs, and an off-track one, and those are the images, the lines for the glenoid tract.
I think anyway, for everybody's benefit, I must tell that Sujit is a wonderful painter.
Thank you.
Unbelievable painting. So if you see those images, suddenly I just recapitulated that he's an amazing painter.
Thank you, Raghu. So let's come to the options here. So how do you go forwards?
The management part, Sujit, I think we'll be discussing in the subsequent discussions that we are going to have on this forum. And if we have to summarize the entire talk here, and because of the lack of time, we would be cutting into the presentations of the others, and we would take it up in the coming presentations. If we have to take two images to say, I will calculate this way the glenoid and I will calculate the hill sacs in this fashion, which are the two go-to images that we should look for in calculating the bone losses? Aditya and Vivek and Sujit and any other presenter if they are there. Quick.
So on the glenoid, you're either going to go with the on-face image or the 3D image, because that's going to give you the best sense when you're looking at CT. Okay. And when you're looking at the axial, and I think the key thing in that is to make sure that you're understanding the obliquity of the image, because that will cause you to measure things. And as far as the CT, the humeral head bone loss goes, I think you must look at the coronal and the sagittal images and find the axial image, which looks like it has the most or the largest hill sacs in the axial plane, but off of the coronal and sagittal images, so that you're not looking at some random slice for where you think the thing, and realizing that oftentimes these are sort of on the very superior sections. So you need to be careful about looking for the exact spot where you have the best look at the hill sacs lesion.
Okay, Milind sir, you want to add anything? You had come out on the screen.
Yeah. So actually, I wanted to ask Aditya the same thing. That when he talked about the humeral side bone loss, he compares the axial and the coronal images together, and then it is calculated with a combined effort. So there is no one single image which is going to give you a humeral side bone loss.
No. So the one image, it's just that it is the axial image that you're going to measure it on. It's just that which axial image will be decided by
will be
looking at
corresponded by a coronal section, correct?
By sagittal and coronals, actually. In fact, sagittals are very, very helpful.
Okay.
Yeah.
So thank you guys for the nice presentation on behalf of the arthroscopy study group. I thank all the presenters, all the faculties that were there for discussions, and all the viewers who were there viewing this wonderful discussions. On behalf of the arthroscopy study group, I thank MCure for sponsoring this deliberations, and looking forward to meeting with all of you again in the coming days. Stay safe, stay healthy. On behalf of Roshan and team, we are signing off from the